So we are so happy to have Dr. Jagroo, if I'm pronouncing that correctly, with us today. She is a board-certified clinical specialist in women's health physical therapy. She's been a pelvic rehab specialist for over 2 decades and has worked with a wide range of patients, including cancer survivors. Today, she is going to teach us about pelvic health, how to find and strengthen your pelvic floor muscles, and how cancer treatment may affect sexual function. So if you have any questions, as always, please put in the chat. You can message Jillian or I directly to ask them for you, or we can have a Q&A later in the chat. So thank you so much, and I'll hand it over to you, Dr. Jagroo. Thank you.
Thank you so much. Can you see my screen?
Yeah.
Thank you. Thank you so much for having me. I've done some of these talks in the past, and I'm just honored to be back to be talking with you about pelvic floor and, like Carly said, to find your pelvic floor, how to treat your pelvic floor, and how cancer treatments may affect the pelvic floor and sexual functioning. So I'm going to start really quick. It's a little bit about me. I know she gave a little bit of an introduction, but I am a board-certified clinical specialist in women's health physical therapy. I work at the Manhattan Veterans Hospital. I've been here for 22 years, so over 2 decades working with male and female veterans with pelvic floor dysfunction. I am also an NYU professor where I teach pelvic floor rehab to the NYU doctoral students, physical therapy. I'm also a private practice owner, and I'm an author as well. Okay. So we're going to talk a lot about the pelvic floor. Where is it? What is it? In general, it is a whole compound structure. It's just not one thing. It's not just muscles or ligaments or bones. It is a whole compound structure of layers and layers of muscles and tendons and ligaments and connective tissue that close off the bony pelvic outlet. I'll talk more about that in detail. But there's just many muscles that all work together in conjunction to help do different functions in the pelvis, which we'll talk about in a minute. Okay? So let's talk about where it is. So if you're looking at this picture and you're looking at this person, this is someone born female, and you're looking at them from the side, right? So the spine would be in the back of the pelvis, right? And if you were moving more towards the front, the bowels, the rectum, large intestine would be like one layer in. And then uterus, if you still have uterus, would be in front of that. Bladder would be in front of that, and the pubic bone would be towards the front. So under all of that, that red sling is the pelvic floor muscles. It's just represented by that one line, but there's layers and layers of muscle. Okay, so it's basically supporting those pelvic organs from underneath. So this is a video. It takes a minute to load, but it talks about, really quickly shows you the pelvic floor muscles in the female pelvis. If it does load, if it doesn't load, we will just move on. I'll give it 30 seconds.
The pelvic floor is the base of the group of muscles referred to as your core. These muscles are located in your pelvis and stretch like a hammock from the pubic bone at the front.
We're not seeing the video. At least I'm not.
Yeah, it looks like it's stuck on the first page. Sorry.
Okay, so if you were, let's say you were laying down, and this would be how if you could see it at all, this would be how it would be like configured in your pelvis. So like the bladder would be like towards the ceiling. If you still have uterus would be underneath that, and the rectum would be underneath that, and then the pelvic floor would be supporting that, like from the point of view of your legs, right? It would be supporting your pelvic organs from underneath. Okay? So there are 5 functions of the pelvic floor. We call them the 5 S's. So one is sphincteric, meaning that they wrap around the base of the bladder and they wrap around the base of the rectum. So just like you would have a urethral sphincter, a sphincter at the base of the bladder to close off the bladder, or the sphincter at the base of the anal sphincter at the base of the rectum. These are what these muscles do. They close off the bladder and they close off the rectum so that you don't leak. So they're super important. Sump pump is the next function, meaning by contracting the pelvic floor muscles, it helps to push out the blood. It helps to push out like fluid that can accumulate in the pelvis. Support is the next S, and that means it is connecting to your pelvic wall. It is connecting to the bones and supporting the pelvic bones and supporting the pelvic organs from underneath. Stability, same thing. It's connecting to the bones and underneath the pelvic organs in order to support and stabilize. And also these muscles directly connect to the clitoris, so they directly affect sexual functioning. Also, they wrap around the vaginal canal, so they affect orgasms and they affect like the strength and like consistency of strong orgasms. Okay, we'll talk about that in a little bit. Why is it important? There's different fibers in the muscle. So on the one side, there's quick recruitment fibers, meaning the fibers that kick in when you cough, laugh, or sneeze. They jump in to close off the bladder so you don't leak urine. And they also jump in to close off the rectum so you don't leak gas and you don't leak stool. Okay. Then there's endurance fibers. These are the fibers that kick in when you're on a long bus ride or you're on a long train ride and you need to hold in urine or hold back gas until you make it to the bathroom. So there's different types of fibers. And when you're doing pelvic floor exercises, you need to work both of those sets of fibers. And we'll talk about that a little bit at the end. We'll do a little bit of practicing. So how do we keep these muscles strong? We do Kegel exercises. So what are Kegel exercises and who is Kegel? So there is a man, of course, GYN from the 1940s, who identified the exercises to strengthen these pelvic floor muscles. The muscles themselves are called the levator ani muscles, but the exercises to strengthen them were named after him, and his name was Arnold Kegel, so they call them Kegel exercises. Hello? Kegel exercises, and so they'll call them the Kegel muscles or the Kegel exercises, right? So we'll practice a little bit of them later, but that's what they're called, Kegel exercises. And the important thing about this is if you don't use them, you lose them. They're just like any other muscles. If you're not exercising them, they can become weak. Okay, and the hardest thing is just finding them because they're on the inside. They're on the inside of your pelvis. So if they're on the inside of your pelvis, it's not like you can see it. It's not like you can see your bicep, right? Where you can like make a muscle and you can see in your arm that your muscle is contracting, or, you know, maybe contract a muscle in your thigh and you can see it. These muscles are on the inside. So what often happens is there is a contraction of other muscles and people think that they're contracting their pelvic floor muscles, but they're not, you know, and we'll talk about different compensations that people do and use when they're trying to squeeze and find their pelvic floor.
I think it might have frozen again, but I did receive your email. Do you mind just stop screen sharing and I'll share it? Is that okay?
Yes. Perfect.
Sorry, just give me 1 second. Were you up to here?
One more, I think.
Okay,
Maybe two.
how's that?
One more. Okay, one more. Okay, perfect. So who has a pelvic floor? A lot of times men think that they do not have pelvic floor muscles. Men have pelvic floor muscles, women have pelvic floor muscles, everybody has a pelvic floor. So, you know, people may just not feel so in touch with pelvic floor because they can't find the muscles. But the important thing is trying to find the muscles, building awareness, and trying to improve the control of these muscles. So learning how to contract them when you need to contract them and learning how to relax them when you need to relax them. Go ahead, next slide. So the National Institute of Health says that 1/3 of all US women will develop pelvic dysfunction in their lifetime. And what is that? That is a huge statistic. If there's like 300 plus million people in the United States, half are women, and if 1/3 of that, we're talking more than 50 million women, will develop pelvic dysfunction in their lifetime. And the problem is there's not a lot of information or correct information out there, like not even on the National Institute of Health website. There's, different categories like heart health and diabetic health and stuff like that. And that has smaller numbers actually of, how many women are suffering from diabetes or cardiac health issues. But there's a lot more information out there about that. It's not easy to find correct information about pelvic floor and pelvic floor dysfunction. But I think everybody has some kind of issue with their pelvic floor at some point in their life, right? So I think everyone at some point pees when they sneeze, drop a little bit of urine, or toots a little bit when they cough at some point. So I think everyone can benefit from pelvic floor rehab or learning about pelvic floor resources or information. Next slide. This is a way to think about it. It's this boat in a dock analogy. So imagine that your pelvic organs are represented by the boat. So the bladder, the uterus, the rectum are the boat. Okay. The water underneath the boat is represented by your pelvic floor muscles, right? So they're supporting the boat from underneath. The ties to the dock are the ligaments and the connective tissue anchoring your pelvic organs to the pelvic wall. So over time, these ties to the dock, the connective tissue, the ligaments, the tendons, they tend to get weak. And so there's a lot of stress on the ligaments because the boat is hanging in the dock, right? And what we need to do is to build up the amount of water underneath the boat to support the boat better. And so we need to strengthen the pelvic floor muscles to offer more support from underneath. So there's less tension, less stress on the ties to the dock. There's less tension and stress on the ligaments and the connective tissue, anchoring the pelvic organs to the dock, right? So our goal is to try to build the amount of muscle and the strength and tone in the muscle underneath the boat to support it from underneath. Next slide. So think about it as like a hammock, right? The pelvic floor muscles are a sling of muscle underneath the pelvic organs. So a toned or strong pelvic floor is like a good supportive hammock, right? But when you have like a droopy hammock, that's represented by a weak pelvic floor. So it's not offering as much support. There's not as much tension in the ropes, and may not offer you so much support if you're laying in the hammock. Go ahead, next slide. Okay, so we're just going to do a silly little exercise to try to find our pelvic floor muscles. So if you can, this is hard to do, I think, but try to sit on your hands. I know that's like weird, but I want you to sit up nice and tall. You're going to try to sit on your hands. Find your pelvic sitting bones, those sitting bones in your pelvis, and try to sit on your hands so that your hands are kind of hugging those bones. Okay, and what you're gonna do is close your eyes and you're gonna imagine that you're in an elevator, and you're in an elevator with your favorite movie star, your idol, whoever that is. And that person is standing behind you in the elevator, and you are the only person in the elevator with this other person that you admire very much and you want to impress. So imagine that you just drank a lot of water, and you just had a burrito and you're super gassy and you need to hold in some gas. Right? And you were in an elevator, so you cannot let it out because your favorite movie star knows that it would be you. So you need to try to hold it in, and you need to look cool, meaning you cannot tighten your butt muscles, right? Because they can see it. You can't booty clench, what we say, right? So you're gonna relax your butt muscles, and you're gonna try to tighten the muscles to hold in urine and hold back gas, okay? But you can't booty clench. You have to be really relaxed otherwise, okay? And technically, if you're doing it correctly, you'll feel the pelvic floor muscles kind of bulge into your fingertips because they kind of bulge downwards in between those sitting bones if you can manage, okay? So try to do that. I want you to try to squeeze as if you're trying to hold in urine or hold back gas, and see if you can feel the muscles bulge into your fingertips. Okay, so that is super hard to do, right? It feels hard, and this is just trying to find the muscles. So what are some of the things, if you'd like to share, what are some of the things you feel like you were doing maybe instead of contracting your pelvic floor muscles? Were you contracting another set of muscles? Are you tightening something else maybe? Well, a lot of people they tend to squeeze their butt muscles instead, right? They squeeze their butt muscles or they squeeze their thigh muscles. So when people have to go to the bathroom, they tend to squeeze their thighs together, right? That's just kind of a natural reflex. So sometimes people, they suck in their stomach, or sometimes they hold their breath, right? And these are things that people do instead of contracting their pelvic floor muscles, and they think they are contracting their pelvic floor muscles, but in reality, they're squeezing all these other muscles, which is very natural to do. So the whole point of like pelvic rehab is trying to find the muscles and then try to strengthen them when you're supposed to strengthen them, and contract them and relax them when you're meant to relax them. So it's hard to find them because we tend to just squeeze other muscles instead because we can't see them. Go ahead, next slide. Okay, so another thing that people tend to do is they'll stop their pee. So they'll stop their urine flow to try to strengthen their pelvic floor muscles. Now, there's nothing wrong with, like, if you're peeing and you want to see if you can find the pelvic floor muscles and you want to stop your stream of urine to identify the muscles, to just find them, that's okay. But you do not want to get into the habit of like constantly stopping your urine flow to try and strengthen your pelvic floor muscles, because you're sending the wrong signals up to the brain about, you know, what your pelvic floor muscle is supposed to be doing. So when you're urinating, when you're voiding, the sphincter and pelvic floor muscles are supposed to relax, right? So you don't want to send these confusing signals up to the brain about like what your pelvic floor muscles and the sphincter are supposed to be doing. So another thing is, a lot of times there's like a residual. Every time you stop your urine, there's a little bit of residual, which can lead to a urinary tract infection, and we don't want that, right? You want to eliminate urine from your bladder completely. So we don't want to send the wrong signals. We don't want to have it lead to a urinary tract infection. So to find the muscles, yes, you can squeeze your pelvic floor muscles during urination, but don't get in the habit of doing that often. Okay. Go ahead, next slide. Okay, so what can go wrong? These are muscles, just like any other muscles, okay? So it can be that the muscles can get weak. It can be that the muscles can be tight. Again, these are muscles just like any other muscles, okay? So if the muscles are weak, you have one set of problems. If the muscles are tight, it can lead to other problems because these muscles are wrapping around your pelvic organs. So they're wrapping around your bladder, they're wrapping around the base of the bladder, they're wrapping around the rectum, they're wrapping around the vaginal canal. So if you have like a tight bicep, it's not going to cause the same kind of issues because it's very isolated to just your arm. But in the pelvis, it's so complicated because you've got all these really important pelvic organs belonging to other systems, right? Gastrointestinal system, genitourinary system, reproductive system. So it can cause lots of issues if these muscles are tight because they can lead to spasms and trigger points, and it can affect the functioning of these muscles. Okay, next slide. So if you're weak, let's say the muscles are weak, like I said, they can be just like any other muscles, they can be weak. So it can lead to incontinence, and incontinence is leaking from those organs, right? So you can be leaking urine, you can leak gas, you can leak stool. So fecal incontinence is leaking gas or leaking stool. Urinary incontinence, obviously leaking urine. Another issue that can happen is a prolapse. And so there's layers and layers of muscle, right? There has to be a space for those organs to eliminate, right? Its contents. So the bladder needs to have a space to eliminate urine. The large intestine needs to have a space to eliminate stool. The uterus, you need to have the vaginal canal in order to deliver a baby. And so you need a space and to block all those outlets. And because there's a space, there's potential for those organs to come through, right? So those organs can drop due to weakness in the muscles and that supportive structure, and also of the connective tissue. So there's a lot of different issues that can cause a prolapse, but that's what prolapse means. It means the dropping of, it could be any of the structures. It could be dropping of the rectum, it could be dropping of the uterus, it could be dropping of the bladder, but it can also be like dropping of part of the vaginal wall or the small bowel or part of the cervix. It can be anything in the pelvis that's kind of drooping, and that's a prolapse. That's what can happen when you have weakness of the pelvic floor. On the opposite side, you can have tightness. And just like I said before, these muscles can have spasms, they can have trigger points, just like any other muscle that is tight, except that it's a problem because it's in the pelvis. So you can have pain with intercourse because you can have trigger points and spasms in the muscles wrapping around the vaginal canal, or you can have pain from adhesions in the connective tissue, or the muscles can be tight and be connecting right to the clitoris, so they can cause pain with arousal and orgasm. You could have pain sitting on hard surfaces because the muscles are spasming every time there's pressure on them. You can have pain with movement. You can have pain going to the bathroom. These muscles are wrapping around the rectum, wrapping around the base of the bladder. So you can have problems with voiding because they're too tight. Next slide. So with incontinence, with the leaking, this is with weak pelvic floor muscles, right? So weak pelvic floor muscles, you can leak gas, stool, or urine. So on the urinary side, you can have stress incontinence. This is leaking with exertion, meaning if you cough, laugh, sneeze, exercise, change positions, there's a change in pressure in the abdomen. So that can like put downward pressure on the bladder and cause you to leak urine. Urge incontinence, also called key and lock syndrome. So that means like when you have a strong urge to go to the bathroom, like you have to go at that minute, you can't make it to the bathroom and you leak urine. And this could be from a number of issues. It could be a signal problem from the brain to the bladder that's not allowing you time to get to the bathroom. It can be because you start to feel anxious because you're not near a bathroom maybe, and you increase intra-abdominal pressure, puts pressure on the bladder, causes the bladder to contract, and you lose a little bit of urine. So there's, that's called urge incontinence, and it's called key and lock syndrome because people sometimes have to go to the bathroom and they're trying to get in their door and they're like fidgeting with the keys and they get really nervous and then they end up like leaking some urine when they are like at the door trying to get into their apartment or house, trying to get to the bathroom. So that's called urge incontinence. Again, fecal incontinence can be that you lose gas. Maybe you cough and you toot a little bit. So that's also fecal incontinence in addition to stool feces. Go ahead, next slide. And again, just because it's common doesn't mean it's normal. It is very common for people after they have children to be leaking, or maybe even after certain surgeries. But it doesn't mean it's normal. These are muscles, just like any other muscle. You can rehab them, you can strengthen them. You just have to find them. That's what's so hard about pelvic floor rehab, is finding the muscles. It is identifying the muscles and trying to connect the muscles that are on the inside and you can't see them. So people tend to squeeze the wrong muscles. That's usually the problem. Next slide. So another thing that can affect having accidents and the quality and tone of the pelvic floor muscles is drinking or eating things that may make it more difficult for you to maintain continence or to not leak. So let's talk a little bit about bladder irritants and bladder function. So you can go to the next slide. So normal bladder function in general is you should be urinating like 5 to 7 times a day, 6 to 8 times a day. That's normal functioning, okay? An amount of urine at each void, this is like 1 to 5, like 1 cup of urine, that's kind of a lot. But there's always going to be a greater urine output in the morning. And that's because your body knows that you're sleeping and technically you're under the age of 65. You shouldn't be getting up at night to go to the bathroom. You should be able to hold it. There's a greater processing of urine during the night. And you shouldn't be getting up technically to go to the bathroom. There are age-related changes that happen. And sometimes cancer treatments can affect the urethral tissue. But overall, a lot of times getting up during the night, which is called nocturia, is a sort of a habit that's found that's formed, and it's not that it's anybody's fault in that sense. It's just that for the bladder, when it's filling up, you get signals when the bladder is a certain amount full, which we'll talk about in a minute. And sometimes we react to that signal by getting up and going to the bathroom. And technically, the job of the bladder is to store urine. So it doesn't mean once you get that signal that you have to get up and go to the bathroom. But people tend to get that signal and they get anxious and they feel like, oh, I have to go to the bathroom now because I don't know if I'm going to get the chance to go to the bathroom again. So they go, and then you get in the habit of allowing your bladder to wake you up, and you behaviorally decide to get up and go to the bathroom, and that becomes a habit. And the more you get up during the night to go to the bathroom, the more you're responding to that signal, the more those sensors in the wall of the bladder reset and start telling your brain when there's less and less urine in the bladder. So the more you ignore that signal, if you are not peeing all over yourself, if you ignore that signal, then those sensors tend to reset, and the receptors will tell your brain when there's more and more fluid in the bladder. But again, if you can ignore that signal at night, if you don't feel like you're going to pee on yourself, try to ignore that signal, because the goal is to not have your bladder wake you up at night and to get as much of a full night's rest or as many hours of stretch of sleep at night as possible so you don't feel so tired in the day. But a lot of issues with bladder and getting up and going to the bathroom too much during the day or at night is from like behavioral habits that people tend to pick up along the way. And you can retrain yourself. You can unlearn those habits. It takes some effort, but you can unlearn those habits. Okay, so again, try to ignore that signal at night if you can. One time a night maybe is okay, but try not making it like 3, 4, 5, 6 times a night to go to the bed. Avoid bladder irritants. We'll talk about that in the next slide. Anything that is going to irritate the lining of the bladder is going to make you feel like you have to go to the bathroom even when you don't have to. It's best to have 2 liters of water a day. That is a lot of water, but more water and pure water is the best. Go ahead and go to the next slide. So think about anything that is carbonated, anything fizzy, anything bubbly, it's going to irritate the bladder, make you feel like you have to go when you don't have to go. The biggest bladder irritant, caffeine. So coffee, and I know people are really like emotionally attached to their coffee, but like caffeine is going to make you feel like you have to go, especially if you don't have to go. So that's the biggest bladder irritant. And I'm not saying you have to cut out coffee. You don't have to cut out coffee. Just know that caffeine makes things worse. Right? So like 1 cup is like acceptable, but like, you know, some people do 2 cups in the morning and a cup in the evening, or, you know, so think about you drinking things close to bedtime too, like that's going to affect your sleep, and that's going to affect your bladder processing the urine, right? So you don't want to be drinking anything that's going to be irritating your bladder close to bedtime. If you're going to bed like 10 o'clock at night, you should be not eating or drinking 3 to 4 hours before you go to bed, because you want to eliminate as much as you can before and not during your nighttime sleep. So you don't want to be drinking anything that's going to be dehydrating you, so that you feel like you need to get up in the middle of the night to drink water. You know, have a humidifier in your room. You don't want to, I say only have water by your bedside if you need to take medicine in the middle of the night, but people get in the habit of getting up and drinking. And then that like starts a whole habit. Then they go to the bathroom because they're up. And then, you know, it could also increase risk for falls. So you want to make the nighttime sleep habits as healthy and safe as possible. So anything citrusy. So what do we talk about? Caffeine, anything carbonated, anything citrusy, right? So like fruit juices, orange juice, like that'll irritate the bladder. And I'm talking about any time of day, not just like at night, right? Anything acidic is going to irritate the bladder. Anything, I'm missing one. Oh, alcoholic. Anything alcoholic, wine, beer, anything like that is going to irritate the bladder. The best thing really is pure water. And people say, what about tea? What about this? And I said, anytime you mix something with water, it is binding to the water molecules and not allowing the water to really flush out the bladder. So not that it's bad, these things just may contribute to your symptoms. Okay, next slide. So that's bladder. Let's talk a little bit about bowel, and this is all affected by the pelvic floor muscles because they wrap around the organs, right? So everything's affecting everything else. So bowel habits, 1 to 3 bowel movements a day is normal. You can have up to 3 bowel movements a day, and that's okay. Every other day is okay. Anything less than that, no good. That's constipation. And what does that mean? That means you're straining to go to the bathroom. If you're straining to void, you're working those pelvic floor muscles way too much. So they're going to be overworked, and they're going to be like developing spasms and trigger points, and that's going to affect all the other organs, and that's no good. So you want to be making sure that you're drinking as much water as you can, eating your fiber, and taking anything that is going to like make your flow of stool as easy as possible. So no straining to empty. Keep drinking lots of fluids to keep your stool soft so you're not straining. Lots of fiber in the diet. You know, if you're taking supplements or medication, do that if necessary. And then toileting posture is really important. So the actual best position to poop is like, squatting like over a hole in the ground, but we don't do that here. So you have to try to get into that position where you're leaning forward or having your knees higher than your hips by using a stool. There is something called a squatty potty that is like a little stool and like it tucks away under the toilet when you're not using it, and you can just pull it out and put your feet up on it because it actually puts your anorectal angle at the right angle to allow for free passage of stool. There is a muscle that wraps around the rectum. If the muscle's too tight, it's going to pull on the rectum too tight, and it's going to make it that you cannot go to the bathroom smoothly. So you need to be able to relax that muscle, and this angle and this position puts that muscle and the angle in the best position. So if you're, you can lean forward on your knees, you can just step on something, a book or something, I don't know, like at the, in your bathroom, just put your feet up so that your knees are a little higher, and it helps with free passage of stool. And again, lots of water. Go ahead and next slide. So the urge incontinence, that is the key and lock syndrome, right? That's when you're like fidgeting with the keys, you're trying to get in the house, you have this like really strong urge to go. So you end up, no, it's okay. No, you were in the right slide. The key and lock one. Yep, right there, go back one. Key and lock syndrome. So that is, you have anxiety, it increases your intra-abdominal pressure, that causes your bladder to contract and expel a little bit of urine. So one thing you can do to buy yourself a little bit of time, if this is happening, if you feel like you're getting a strong urge and you're just like peeing on yourself, can happen sometimes if you're experiencing like a urinary tract infection, like really strong urges to go to the bathroom. You can do 5 or 6 contractions of your pelvic floor muscles. If you can find your pelvic floor muscles, if you squeeze, for whatever reason, it helps to activate the sphincter at the base of the bladder, and it relaxes the bladder wall, and it will buy you time. It will buy you seconds, whatever, so you can get to the bathroom. I'm not exactly sure why. I don't really understand the neurological mechanism of it, but like if you're on the way to the bathroom, obviously try to like talk yourself down and try to relax. But then also if you did a couple quick contractions, squeeze, it relaxes the bladder and it activates the sphincter, and it just will buy you some time to get to the toilet. Okay, go ahead, next slide. Okay, so here's a question. When does the first signal go from the bladder to the brain to tell the brain that there is fluid in the bladder? Do you think the first signal goes off when your bladder is a quarter full, a half full, 3/4 full, or when the bladder is completely full? When does your brain get that first signal?
When it is 3/4.
Actually, half. That's a good guess, though. It's a good guess. So when the bladder is half full, you get that first signal going to the brain that there is fluid in the bladder. Now, that doesn't mean you have to get up and go to the bathroom. And this is when people start to develop those habits of urinary frequency, going to the bathroom often because they're like, oh, there's fluid there. I should eliminate. And that is not the case. This is just a signal, right? Again, the job of your bladder is to store urine. So you don't want to get in the habit of going often, right? So you want to be going just 5 to 7 times a day, 6 to 8 times a day. You don't want to be going every half hour. You don't want to be going every hour. And this is what happens is people start to respond to that signal and they get up and they go. But that's a behavioral decision to get up and go to the bathroom. So you want to try to develop better habits by ignoring the signal. You should be able to hold it longer than an hour. So we'll talk about that in a second. Go ahead, next slide. Okay, how many times a day is it normal to go to the bathroom? So I've been saying it. So it's 5 to 7. 5 to 7 times a day is normal to go to the bathroom to urinate. It's different for bowel movements, right? How long is it normal to wait in between trips to the bathroom? 1 to 3 hours, 2 to 5 hours, or 5 to 8 hours?
2 to 5.
2 to 5, yes, yes, 2 to 5. So you should be able to hold it at least 2 hours, and you should be holding it no more than 5 hours. And I saw something about teacher syndrome, and I think that this is what happens when I'm treating patients who are teachers. They hold it for 8 hours, right? Because they can't get to the bathroom, and I don't know if that's what teacher syndrome is, but I didn't read the full message, but that I tell them you have to set an alarm. You have to eliminate. You don't want to be going too often, because that is no way to live, to be constantly going to the bathroom. You should be able to hold it at least 2 hours. And then you shouldn't be holding it more than 5 hours, because you don't want the urine to become toxic and then really irritate the bladder lining and then cause a urinary tract infection. So you want to be eliminating at healthy intervals, right? So at least 2 hours up to 5 hours. Okay, and some people are really proud about how long they can hold their urine. They'll be like, I'm like a camel, I can hold it for 2 days. And you don't want to do that. You want to just keep eliminating, right? Because you want to keep the bladder lining healthy. And you're going to do that by eliminating in healthy intervals. So, and sometimes it's what I do with patients is I put them on a schedule. I say, if you're going too infrequently, I have them set an alarm, and you have to, when you hear the alarm, you have to go to the bathroom and eliminate, keep your bladder healthy. And if they're going too often, then we start increasing the interval little by little to see if they can handle going, instead of every 30 minutes, to go every 45 minutes. And once you can ignore the signal at 30 minutes, your brain won't even pick up that signal after a while. How many times is it normal to go to the bathroom during the night? We talked about this. It is 0 to 1. So I will read this whole message in a bit, because I want to know what teacher syndrome is. So it is normal to go 0 times a night, and healthy 0 times, unless you're 65. So it is it's okay, because there are age-related changes that happen in the urethra and the pelvic floor after 65. Again, how many times a day is it normal to have a bowel movement? We talked about that. 1 to 3 times a day is normal. Once every other day is normal. But anything less than that is no good, because you're constipated and you're straining and you're pushing too much. And that's overworking the pelvic floor muscles. We talked about the squatty potty. Really good to have your knees above your hips, so that it creates a better angle and easier time for you to have free passage of stool. Next slide. So pelvic pain, like I said, these muscles, they can be tight. They can be weak, but if they're tight, it can cause pain. You're gonna have pain with movement. You're gonna have pain sitting on hard surfaces. This could lead to chronic pain, because sometimes it starts with something so simple as a urinary tract infection, and then people start to have pain when they urinate, so they tighten up, and then they end up with constipation, because those muscles are getting tight and they're pulling on the rectum, and that leads to pain with intercourse, because these muscles also wrap around the vaginal canal, and then it just leads to more and more problems. It just starts to snowball. So this can lead to other issues with movement and sitting on hard surfaces. Pain with intercourse specifically is called dyspareunia. And dyspareunia just means, it's a general term, pain with intercourse, but pain can be at the vaginal opening. Pain can be externally, at the level of external female genitalia. The pain can be along the vaginal canal. So there are different places that pain can, or deep in the pelvis, from deep abdominal aching from spasming of the pelvic floor muscles with deep penetration during intercourse. And we would treat those all different ways. And it has to do with the muscles, and there are different ways to address this, but it could all be from tight pelvic floor muscles affecting different phases of intercourse. Next slide. Okay. There are cancer-related sexual issues. So there are issues from the cancer treatments, the decreased estrogen. It can lead to dryness, and that can lead to pain with intercourse. Pain can be from chemo treatments and radiation and or surgeries. It can lead to adhesions. It can lead to just immobility of the tissue, decreased pliability of the tissue, which can lead to pain. It can lead to spasms or trigger points in the muscles that wrap around the vaginal canal that affect orgasm. It can affect the muscles that are connecting straight to the clitoris that can cause pain with orgasm and arousal. Atrophy, so like thinning of the tissue that can affect comfort or discomfort with intercourse. Fibrosis, like thickening of the tissue over time as a reaction to medication. Fatigue is a big issue with intercourse, and issues with intercourse, just not having the energy to be able to be intimate. Scar tissue from all the treatment, nerve injury from surgery or from treatment. Decreased sensation can affect arousal and orgasm. Weakness in the muscle, limited range of motion, perhaps in the hips, and limited mobility again in the hips. Next slide. So there's the sexual response cycle. There's different phases of orgasm with being intimate with a partner. You and your partner don't have the same cycle, like at the same rate, but there's desire. The next phase is excitement. It plateaus. There's orgasm, and then resolution. So a lot of times with cancer treatments, there is, for females in particular, like decreased excitement, extended phases, like extended plateau phase. You may need more stimulation for orgasm, and there may be like depressed and elongated phases throughout the sexual response cycle. Next slide. So what can you do about it? Physical therapy. We work with the pelvic floor muscles, helping you find these muscles, stretching, strengthening, mind-body calming techniques. We have something called biofeedback. I'll show you that later. Manual techniques to help you work on the trigger points, to release the trigger points, to help stretch the muscle. There's muscle energy techniques, which are gentle techniques to help the muscles relax. Behavioral modifications, like I said, it's like trying to figure out if like maybe you're answering this signal from your brain too quickly about having to go to the bathroom, just changing habits, changing what you're drinking, changing what you're eating. Maybe all of that is affecting, your lifestyle, going to the bathroom too much, and the tone of your pelvic floor muscles. There's something called dilators, exercise tools. I'll show you pictures of these, so go ahead. Move forward. Something on the left that's called the Liberator, and it is, I've ordered this for my patients who have had like cancer treatments and they just have fatigue and it affects their sexual functioning. So it helps with positioning and like depth of penetration during intimate encounters with their partner. Again, it's called the Liberator Wedge Set, and it's for patients like MS patients, cancer patients who have issues with fatiguing during intercourse. The O-nut on the right side is for the penetrating partner who is having intimate relations with someone who cannot tolerate deep penetration with intercourse. So those rings kind of come off like one by one. And so it helps with the female partner to adapt and adjust to like deeper levels of penetration, like a little bit at a time. So if they're having pain with intercourse, it just helps with like stretching the tissue. And so the male would wear this, the penetrating partner would wear this, and then the more that the woman could tolerate, the female partner, they would remove one of the rings. I'll show you some dilators. Okay, so these are some wands that I use with patients who have like internal trigger points. So all of these different colored wands actually do something different. So the yellow one, it holds temperature. So you can hold it under the faucet and it'll be either warm or cold for 10 minutes and hold temperature. The teal one vibrates, and the purple one, I forgot what the blue one does, but the purple one is just a regular one. It's silicone based. And you could use either side. So these could be for rectal trigger points. This could be for vaginal trigger points. And I have patients use this. They insert it vaginally and they can reach like parts of their pelvis on the inside, the muscles on the inside, and try to release the trigger point where they, can't reach it otherwise. So it feels really good to work on the connective tissue and work on trigger points and stretching the vaginal tissue with this. Next slide. The dilator on the left, it's the purple one. It's called a Millie. It's new, and I think it's pretty fantastic. It's one device, and it has just these buttons. You turn it on with one button, and then there's a plus sign and a minus sign. And what it does, it starts off basically the size of a finger, and then when you press the button, it expands, and it goes up like 1 millimeter per push a button, and it can go up to 25 millimeters, like basically the size of the biggest dilator of that picture on the right. And it helps to stretch the vaginal tissue without you having to change the parts, change the attachments. So if you look on the right side, those are dilators, right? So the gray thing is a handle, and those dilators, they fit into the handle one by one. And you would use it to stretch the vaginal tissue, work on trigger points, work the tissue around one of the nerves in the vaginal canal, and then keep switching out to the bigger ones so that you can stretch in bigger increments. Okay, next slide. Biofeedback on the left, that is a unit where you would insert the little sensor. I don't know if you can see it. It's attached to the cable. And then the little unit, it would like the more you squeeze around the sensor, you would see lights or hear sounds that indicate that you're squeezing stronger, that your muscles are getting stronger. So it's a good feedback. There's lots of versions of this online that you can get that they attach to your, they wirelessly connect to your phone, and you can follow an app if you're tech savvy. But there's great different devices for this. On the right, it's vaginal weights. They're like weighted tampons, and you would insert them one by one with the string hanging out, and you would do exercise. And just squeezing around something is always better than just trying to strengthen your pelvic floor muscles with nothing. So you would do exercise with that in, very controlled amount of time that you would do this. It was not like you use them and walk around with them all the time. So you would do exercises with that, and that would strengthen your pelvic floor muscles. Go ahead, and next slide. And then of course with your partner, communicating, your feelings is so important. If you don't want to be touched, if you want to be touched, if something hurts, doesn't hurt. There's different lingerie that's made for different cancer treatments. If people have had scars, or if they have stomas or something, they have lingerie with different coverings for that. Self-mapping, which is marking on a silhouette or a stick figure, basically where you want to be touched, where you don't want to be touched, and communicating that with your partner in terms of sexual function and intimate encounters, mindful touching, non-judgment, and being in the moment when you're with your partner. Sensate Focus is kind of a program where you get back to being intimate with your partner, but you start with non-erotic touch. So you do massage and just work with lotions, touching each other, non-erogenous zones, and then move towards the goal of having intercourse again, but kind of in staged increments of time. And then different positions that feel good if certain positions are too painful from cancer treatments or cancer surgeries. Next slide.
Dr. Jagroo, I hate to cut you off, but we are pretty much out of time. So if we could just wrap up now, that would be great.
Thank you everyone for joining.